We have a very interesting panel to discuss this subject, and first up, I'd like to welcome on stage the moderator of this panel, Devanand Kolothodi, Regional CEO, Telangana and Andhra Pradesh Cluster, Aster DM Healthcare. Kindly keep the applause going as I welcome the members of this panel. Dr. Hiren Ambegaokar, Chief CEO, Surya Hospitals. Welcome, Dr. Hiren. Dr. Parag Rindani, CEO, Wockhardt Hospitals. Kindly keep the applause going, please, as Dr. Parag makes his way. Dr. Sujit Chatterjee, CEO, Dr. LH Hiranandani Hospital. Welcome, Dr. Sujit. And Vinod Sawantwadkar, CEO, Jahangir Hospital. Can we have Vinod on stage, please? There, he's making his way. Devanand, you know the drill. Over to you.
A very interesting subject and a very powerful panel. So, we all know that the hospitals have really complex structures. You know, you all have been working with the hospitals. So, and construction of hospital is also even more complex and very capital intensive. So, when any denial of a proper infrastructure, it always leads to, loss of human and other resources. In addition, services to the patients, timely availability of equipment, emergency care or efficiency, which can have an effect on the quality and affordability. In that sense, this particular topic has a lot of relevance, especially quality and affordability, evolving needs and scope for hospital infrastructure. So I have a very fabulous panel who can, give their insights on this wonderful topic. So without much further delay, I think I'll start with Dr. Hiren with the first question. So, you know that healthcare, when you compare the public and private, I think public will come a little later. I think you three are representing all of you are representing the private. But anyway, I want some of you to give a public perspective also. But then on the private sector, when you look at it, is there any specific strategies that the private healthcare sector has imbibed to reduce the infrastructure cost in order to, improve the affordability? So do you think anything of that sort has been already in place? Yeah.
Good evening, everyone. As usual, I just made it in time for the venue. And like I've been used to, as in my anesthetist days past, when the surgeon is washed up and waiting for the anesthetist to come, and we come in last moment and say, "Sir, I'm sorry, I have just come here, I'll take it up." I beg your apologies if I repeat something from the sessions already done in the earlier. But as you see, after the pandemic ended, the healthcare is now coming back to normalcy, and we are all grappling with the new normal. And as you're all aware, the private healthcare is still an out-of-pocket expense to a majority of people. Post-pandemic, the insurance sector has spread more, but still it has not reached the extreme ages of the population, especially the neonates and the old people. The old people are still grappling with capped medical insurance because of age, and neonates and infertility patients are out of the reach of the insurance in most of the cases, unless they are corporate patients. Now, for us, I represent a hospital which is predominantly a woman and child hospital chain, Surya Group, and our specialty is neonatal care. We specialize in extreme neonates, which are 450 to 500 grams, and our survival rates are 70%. Now, to maintain this quality and yet be affordable for a population 80% of whom the expense is out of pocket expense is a real challenge. And the only way for us to maintain our position in the market, the profitability in the market, without increasing the tariffs, which would add another burden to the already burdened population, is by reducing our operational costs. And this is something which, as a group, we were grappling with, because we were already having an infrastructure which was old and mature. At the same time, we are expanding further into the metros of Mumbai and Pune by having more units there. So, to grapple with the situation as to how to keep the quality, at the same time maintain the affordability, was always a problem for us. So the way we did it was, first and foremost, we looked at our costs. The main costs are the manpower cost, which constitutes almost 50% of our operational cost. Now, to reduce the manpower cost, we, in our existing units, what we did was we remodeled and restructured our units to such a way that more and more similar groups were together. Like we got the adult ICU and the PICU together where it was possible in our unit in Mumbai, so that the cost could be, shared to a large extent on the nursing and the housekeeping front. In our Jaipur unit, where this was not possible, we got an ICU and PICUs together. Similar grouping, so that we could reduce our operational costs. We got a dumb waiter and a pneumatic chute in place in a facility in Pune where it could be possible to do it, so that it could reduce our costs for the housekeeping and manpower cost. The other main factor which increases the cost is the length of stay. Now that is something which we were trying to get it by reducing our hospital-acquired infections, where the HVAC played a major part. Our hospitals, where the existing infrastructure was not geared for the pandemic, so to say. So we always had a problem where the COVID positive mother delivered a premature baby. We had a problem as to how to accommodate that child. Now that is something now we are looking at in our future hospitals by addressing that front. The HVAC has undergone a major change in our hospitals, and that is where we have reduced our hospital, tried to reduce our airborne infection to a large extent. And we are using that in our newer designs, all in the design stage in our newer units. That was the major factor. Then the next factor which was coming in was our inventory management, because that is again something where by reducing the cost there, by getting more aggregators to supply material, we could get our cost down. Because our product mix is such that when the other units will have a higher or a lower inventory cost, but our inventory cost was 15%. Our aim was to bring it down to 13%. So by that, if we could do that, we could maintain our tariffs without going in for a tariff hike. Though we had an inflationary increase, our rent our group goes into a rent model. So our rents keep on increasing, the salaries keep on increasing. So to keep that cost down, we had to keep our things down. These are our main successes.
Thank you, Dr. Hiren. So you mean to say that the affordability was brought in by re-engineering a lot of processes inside. So sir, you, Dr. Sujit, has been a proponent of quality. You have created a lot of milestones in terms of the quality journey that India has seen. So just sir, I wanted to ask you, what he's saying is that affordability can be brought in by re-engineering and without compromising the quality. So as a proponent of quality, do you think quality and affordability can coexist?
Yeah, affordability and quality can coexist. Now, I just want to add something which is absolutely generic. You can't have a champagne appetite and lemonade income. That we should be very clear on. Now, coming down to what I meant was, the expectation and delivery needs people's education, right? As Hiren just brought out, that you have a neonate, an extremely small neonate, is going to spend lots of time in the hospital before you can discharge the patient. Now, coming back to exactly what you said, with affordability and quality of health care. Now, what is quality? Quality is an outcome of anything which you do with great care, right from here. If you do that, that's quality. Now, like you come into a hospital and somebody greets you very pleasantly, very politely, that itself is, speaking of quality. But I think what you're actually saying is, what's the billing going to be like? That's ultimately, mera bill kitna hai? So, as Dr. Hiren has very clearly pointed out that, there are limitations. Now, if we all get together, now what do I mean? It's got to be top down. The government of India needs to put on the table that they are concerned about the quality of health in India. We are a young nation, and 2 decades from now, we will be almost a middle-aged to an old nation. So therefore, what does the government of India need to do? They need to ensure that the customs duties and the taxations as far as healthcare is reduced. Not the opposite way. There has to be an investment of the GDP in healthcare, and that will address the public system also to a very, very large extent. Now, the basic players in healthcare are the public players. We just provide the cherry on top of the cake. So therefore, the next very important issue is the manufacturers. Now, all of us down the line, all of us in Parag, Hiren, my colleague sitting there, we have to buy the best of medical equipment because that's where quality of care comes down. So the manufacturers have to understand that. A very good friend of mine who's a CEO of a very, very, very good hospital, better than mine. It breaks my heart to say that. But he's come from the manufacturing industry. That means the companies. And he says that the percentage margin is almost 40%. Now, sir, if you reduce that 40% to 15%, I buy less. I buy the equipment for less cost. So therefore, I don't have to look at my depreciation, how much of money I have to recover, what has to happen in profitability. So therefore, we can all reduce the cost by ensuring that we, as citizens, have the responsibility of ensuring that while we profit, we shouldn't profiteer. I hope that, I'm making this point very strongly. The third is the pharmaceutical industry. The pharmaceutical industry, there are some drugs which cost many, many thousands, and you may have to repeat that. Like for example, meropenem, it's a drug. You sometimes need to give it in very high doses. And if you give it at high doses, the patient's cost is going to increase. So, आपका तो बिल ज़रूर बढ़ेगा. अगर ये नहीं चाहिए तो हम एम्पिसिलिन ठोक देते हैं. Oh, मेरा patient मर गया. इससे आपका patient, was seriously ill. So what do? I've got to use the best. Doctor, please do anything to save the patient. Sure. अरे ऐसे बिल कैसे बढ़ा? So, these sort of things will all help to reduce the cost. And then, entering the hospital. Then in that case, what typically happens is, as Hiren says, that personnel cost comes at a very high value, right? Now you have very good doctors, you may have a very good team of nurses. We have to compete with guys in the nursing at least. We have to compete with the Middle East. We can't do that. You can't do that. So therefore, what do? So you marginally increase the salaries almost every year. If you're unionized, maybe every 3 to 4 years. But then it's a big impact. So technically, sir, of course it is possible. Why shouldn't it be possible? It is. If I go to the Taj Mahal Hotel, I expect a certain service. And if you come to any of our hospitals, you will expect a certain level of service. But then, the people who go to Taj Mahal, they don't look at the right side of the bill. They are more concerned with what's happening on the left side. Well, how did you treat me? So if you're ready to do that, we're ready to drop across. So therefore, it is possible. It is certainly a thing that you can afford. But let's all understand that there has to be a direction right from the top. There's no point in saying that, we must be a healthy nation and what have you. Doesn't work. What's the ground reality? If you don't change, then we can't change because you're my bap. So, sir, it is possible.
Thank you, sir. Thank you so much for that insight, wonderful insights. Yeah, so the cheering says it all. So now we go into the little core of the physical infrastructure. That's the topic that we're discussing. So whenever we discuss about a hospital infrastructure, basically, a lot of terminologies like the sustainability, building sustainability. We also saw a presentation by Everest just by showing some building solutions. And also the energy efficiency. This is another terminology always we hear. So where are we? I mean, are we really looking at those energy efficiency and sustainability too, which can have a real impact on the overheads, which can help the patients?
I guess that question's for me.
Yeah, sorry about that.
So good afternoon. So I was just reading up some material, and approximately 60% of Indian hospitals in toto do not reach what is called the Energy Performance Index of the Energy Conservation Building Code. Now, 60% is a huge number. Essentially, what we are saying is that you're wasting money on energy where there are energy efficient options to save that money. Of course, everybody knows the pathway. You go in for an energy audit, you engage with the firm, you shell out some money to them, which in the overall schema of things is going to be pretty pertinent to save that money in the long run. What is important is that up to 42% of energy, this is a CII publication, and also backed up by an IIT Bombay publication, up to 42% of your energy bills could get cut off. I'll share my own example. We work in a Joint Commission accredited hospital. It's a United States Green Building Council Platinum Standard hospital, Wockhardt hospitals at South Mumbai. Despite being energy efficient at the core of the infrastructure itself, we were still shelling out at around 65 lakh rupees at an occupancy of around 50-60 when we started. Now, I think anybody who does the maths, that's a lakh of rupees roughly per occupied bed, and that's a lot of money because we don't make so much money to begin with. We did an exercise wherein we brought in energy auditors. We actually reduced our bill. It was 66 lakh rupees when we started, and we brought it down to 42 lakh rupees per month. Now that, ladies and gentlemen, is core saving, and anybody who knows their P&L well will decipher that this money goes straight into the EBITDA. And if you're a loss-making institution, it reduces your EBITDA. Irrespective, it is profit. Okay? Now what is important is the sustainable part. Do you do this as a one-time exercise and move away? No. You put in measures like, for example, there are multiple electrical measures which you can put in to save electricity. There are water conserving measures. I'd like to applaud CII, AHPI, and even now NABH. Now NABH has got an energy efficiency standard from the 4th edition onwards. AHPI and CII have got awards for green buildings and green hospitals. And I think essentially industry is pushing its way up. There is one more moot point, and since we are sitting on the Economic Times Forum, it makes sense to pass on this message to the government, is that we need to probably be treated like an industry and not be given commercial rates for electricity, because that is another huge saving which we would be happy to pass on at some stage to the patient once we've offset whatever we could. So I think in terms of sustainability, everybody buys energy efficient equipment because it is expensive to begin with, but the costs on energy saving, the efficiencies on energy saving are huge. All of us try to use, and all of us must remember, 62 to 65% of your cost does not come from switching off lights as soon as you exit the room. These are myths. Stop putting those stickers across the building, they ruin the paint. But 60 to 65% of your costs come from heating, ventilation, and air conditioning. So you need to knock that off, keep your temperatures at 24 degrees and blah, blah, blah. It's all well written about. I think one other important point that we need to make here is that a stitch in time saves 9. You need to maintain your equipment, you need to maintain your infrastructure when it starts deteriorating. That is another point towards making your buildings, your equipment sustainable, efficient, and at the same time, to echo what Dr. Chatterjee said, add to the quality of care that you're contributing to the patient. So I think it is possible to make it sustainable, and I think that's something which we all work towards. I think every head of hospital's aim is essentially twofold: increase top line, reduce cost. If you're not doing this, then you're in a question mark position. I think everybody does this, and that's all we're supposed to do. Thank you.
Thank you, Dr. Parag. Thank you so much for that insight. So I think we have mostly got the private sector perspective on how to reduce cost and what are the kind of initiatives that we had. So we actually were supposed to have, somebody from the public sector also, but then he had to go for something urgent. So I want to pose that question to Mr. Vinod. See, now as healthcare leaders, you'll also be looking at the public sector developments in terms of the infrastructure and the investments that the government is making. So what, according to you, the government is doing in terms of improving the public health infrastructure?
Thank you and good afternoon. I think so in last 2 years, if you look what government has done is, basically government is very successful in bringing focus on healthcare. I mean, before that, I don't think so there was so much of focus on healthcare. Maybe private hospitals, or maybe the public hospitals, or maybe the rural as well as urban. So with that focus coming in, what has actually happened is, there are two major issues which, or the major areas which has been focused. Number one is, the role of government has turned out to be a sponsor, with the help of the scheme which is coming, which was initially also existing in the various states by various names, and then it got polarized by Ayushman Bharat. So the role has been always now is a sponsor role. And the second part what we are looking is, we have been talking a lot about digitalization. So if I need to look at, if I put it both these two in our working, day-to-day working, then what we are trying to do is we are basically trying to make healthcare more accessible with the technological intervention, and we are trying to make healthcare more affordable by being a sponsor. What would be really very nice to see is the affordability part, because we just cannot compare two hospitals sitting at two different places and we say that you give a same treatment at the same rate. That's not possible, because every place has its own cost of doing things. One of my colleague panelists gave an example of Taj, and yes, that kind of thing also exists in a hospital, because to create and to work a very sustainable healthcare facility, it comes at a cost, and every place has its own cost. So if government try to focus on, trying to, do it city-wise, I think so that's going to be a more sustainable model. That's number one, which government need to do. And probably some of the hospitals may welcome that. Currently, we see a great amount of resistance in this area. And number three, when we are looking at digitalization, that's something which is extremely good, which is happening, because it has already started, and since morning we have seen there has been various companies and there has been various stalwarts who have been talking and telling us, how is that this ecosystem is going to help to reach out more and more people, because I don't have to speak here the ratio of bed per population, or the ratio of doctor as far as the 1,000 people on nursing. That is actually very distorted, but I think so technology may help us to bring in the efficiency there, and it has its own problem. We have seen this in the morning in the sessions, the accuracy and other things, but the good thing is that it has already started. So since there is a start, I see at some point of time, we have a better outlook for 3, 4, 5 years down the line, wherein we can actually say that if healthcare can be accessible to everyone. So in last 2 years, if something which has happened, I think so the focus has come on healthcare, which is extremely important. And now everybody is talking healthcare, walking healthcare. So that's something which government is very, very successful in doing it. I think so rest, we need to wait and watch how things are coming in.
Thank you, Mr. Vinod. So I'll just start with where he has stopped. So Ayushman Bharat, we have been hearing this Ayushman Bharat, multiple sessions and a lot of discussions it came up. So my question is to you, Dr. Hiren. So you have been a clinician, also an administrator. So what do you think now the public sector and private sector to go hand in hand to create the gap, reduce the gap basically in the infrastructure? Do you think Ayushman Bharat will be able to bridge those accessibility gaps?
Well, what I am about to say now is strictly my personal opinion, okay? So please don't take it otherwise. And I feel Ayushman Bharat is a wonderful scheme. Only thing about that scheme is that it needs to be tweaked a bit for it to give the results which the government is waiting for. Speaking of an hospital chain like ours, like I just said earlier, our forte is neonatal care, and I have 65 beds. My average occupancy is around 48 beds. I have spare capacity there. I would love to use that for Ayushman Bharat, for the underprivileged children, which unfortunately cannot utilize that segment. And if you see, there are very few tertiary level NICUs in the city of Mumbai also. There will be similar situation in other cities. But what has happened, Ayushman Bharat has take everything. You cannot select and choose. Now, I cannot do a delivery in my hospital for 7,000 rupees. But if I have to take Ayushman Bharat, I have to take normal deliveries, I have to do general surgical work, I have to do any other work, which is not possible. And that is the reason why most of the private healthcare sector is not giving its spare capacity to the Ayushman Bharat and the underprivileged section of the society. Now, Mumbai has typically a corporate sector, a charitable trust hospitals, and completely government hospitals. Now, the charitable trust hospitals have to reserve 20% of their beds for underprivileged people. Now, if Ayushman Bharat could be utilized in that 20% of the bed, and within that 2% of that revenue share which the charitable hospitals give, then many charitable hospitals in Mumbai would opt for it. But unfortunately, that is not so. Now, all these kind of things, if they are tweaked, then Ayushman Bharat can be a game changer in healthcare. That's my personal opinion.
Thank you so much. So you have brought in a very important point of unused capacity. So, the sunken capacity is what you're talking about. So, my question is to Dr. Sujit. So, do you envisage, there are a lot of unused capacity in many hospitals, even private, corporate or charitable, whatever nomenclature you put in. So, do you think there is a future where two private hospitals may use unused capacity? In which, say, for example, my hospital is getting full, so I use your unused capacity and admit cases. So, if so, that such a condition can exist in future, what could be a very synergistic model?
It's a very interesting question, actually. I mean, the business models, in my experience, when I started the Dr. Hiranandani Hospital, we didn't have an MRI, but Wockhardt at that time, now Fortius, they didn't have a blood bank, and they were doing bypass surgeries. So Lloyd Nazareth was the man looking after Wockhardt, and I went to Lloyd and I told him, Lloyd, you use my blood bank, I'll use your MRI. So all our MRIs went to Lloyd, and his blood demands for, he said basically the cardiovascular thoracic surgery, so all of that came to me. When he got his blood bank and I got my MRI, we stopped exchanging notes. I tried to raise this with another hospital, which was very close by, and I said that, look, if we can get together, and this is the type of monitors I want, and this is, if you are thinking about a similar type of monitors, we could club it together, and then we approach the, vendor. So therefore, there's got to be an element of trust. I think that's very important. If there's an element of trust, there are mundane issues also. How will the billing be? Will you share my revenue? Because if I'm using your capacity and you're using my capacity, I'm incurring the costs, etc. Those are ops issues. Those can be thrashed out. But the point is the philosophy. The philosophy, sir, is that, and Parag, I'm sure you could also add to it, but I think the philosophy is that, do you trust each other? I mean, look, there is business. You've got to compete, but can you complement? I think that's something that we've not matured into, we've not matured into that complementing each other, Hiren has got a, reputation which everybody envies, and Parag, of course, is, right from Wockhardt, they've been doing, path-breaking work. So it's all there, but I think the, element of trust, that seems to be woefully inadequate.
Thank you, sir. So I think it's more of hope and trust is what you have to build among the private players to get in. So you are actually discussing about the equipment sharing, between Wockhardt and your hospital. So now I bring it back to the infrastructure thing in terms of, the equipment handling or support. Whenever you look at physical infrastructure, the availability of equipment at the right place at the right time is very important. So is there any specific strategies adopted by a hospital in terms of infection control or equipment handling to make it more robust in terms of design? It's for you. Sorry, every time I'm forgetting to name him, it's Dr. Parag.
So, let's face it, damages in terms of biomedical equipment are bound to happen. You're dealing with a plethora of doctors, nurses, technicians who are bound to be a little awkward sometimes, especially when you're dealing with new equipment. I think there is no strategy to prevent breakage except hardcore training. And I think what's very, very important is involvement of the people who actually make the equipment for the first couple of months as the equipment gets installed. We've not seen any major gross things, of MRIs getting demagnetized and stuff like that. But I think what's very important is if you expect that no syringe pump will ever get spoiled in the entire 10 or 50 years of your hospital, that's not going to happen. Infection control, as a microbiologist, I can tell you that we've all got very fancy with infection control now. I think everybody throws CDC jargon at each other. Everybody wants to use only extremely complex disinfectants. I think everybody forgets the fact that today you really only need hot water and maybe a little bit of detergent to wipe floors. Everybody's got into, equipment and floor handling, infrastructure handling with a lot of chemicals. I think one of the things that we learned as a green building was you don't need so many chemicals to keep your hospital clean, and that's probably one of the reasons why when I enter my hospital, I don't feel I'm entering a hospital. It just smells normal, ghar ke jaisa, And I think with respect to all of this, there has to be a hardcore structured training program. We heard the gentleman from Joint Commission earlier, and at the basis of his talk was also everything related to training. But I think what's very important is that the trainers themselves remain knowledgeable as well as up to date. If you have nursing trainers or OT trainers who are still talking about fumigating OTs and ruining equipment with all the aldehydes that we use while we are fogging, if you're talking about housekeeping that doesn't know how to dilute its chemicals, I think what's very important is to give them a dabba and say, इतना chemical, ये लाल line तक जो bucket है, इसके अंदर dilute करने का. The moment you say, put 50 ml in 2,500 milliliters of water, the cause is lost. I mean, today, even if you tell a technician to do it, he's just going to look like this. And I don't think, how many of you remember upper meniscus, lower meniscus of solutions? How to read which solution to be read by. I mean, we complicate things, and I think accreditation probably helps to complicate it a little bit further. Too many SOPs, too many things to remember, 2,2,4,4 quadrabutyl. I don't think infection control is that complicated. You remember the basics of infection control and keep things simple, silly. It's like that. What's extremely important, I think Dr. Sujit touched upon it, is the role of antibiotics. I don't think we are strong enough in antibiotic usage or antimicrobial stewardship anywhere in this country, barring one or two pockets of excellence, maybe like a PD Hinduja, or I think probably the Hiranandani has got some very pioneering work there. A lot of us have still to catch up. I'd just like to touch upon one point related to cost with Ayushman Bharat, because I just was itching to say this. Indian Institute of Management, Bangalore, and AHPI about 4 years ago did a study where they studied the base cost of running a hospital. And the base cost of running a hospital was coming to about 1550 or 1600 in a private hospital and about 1850 in a government hospital without air conditioning. Now, why I'm saying this is that if Ayushman Bharat is based on costing of government hospitals, then it's not even meeting that standard, because if I look at a hysterectomy with 3 days of stay in a hospital at 1850 rupees, and if I get 10,000 rupees when I expected to pay the doctor and give 1 week of medicine and give second sleeper fare back and forth to Dhule or Jalgaon or Jalna, it's not going to work out. The basic maths doesn't work out, which we impressed upon the health minister in May, and we told him, sir, you need to basically get your maths correct. I think as a forum, this forum and all of us together need to be cooperative with, cooperate with the government. But at the same time, the government needs to listen to costs. Niti Aayog sometimes can be a little fudgy with numbers, and I think they need to really take a clarion call and wake up. Otherwise, Ayushman Bharat is not going to serve. I'll give you a simple example. We have a hospital within the Wockhardt group. We do Ayushman Bharat. We do about 100 plasties a month. On an average, I make about 40 lakh rupees loss on just the angiography, angioplasty component. Vinod knows it better than anybody else. He's worked in that hospital. It's a secret. What I'm trying to say is try and work out the P&L of an Ayushman Bharat standalone specialty or a hospital. It does not make sense at current rates. Thank you.
Thank you, Dr. Parag. Sorry for not taking your name 2 times. Sorry about that. So I think time is up. So there's a question reserved for you. Probably we'll have to close in 1 minute. So what do you think could be an ideal model? This is to you, Vinod. So model for healthcare infrastructure that can promote more of affordability. What do you think? Which could be an ideal model of healthcare infrastructure?
I think so. It was more to do with whether the healthcare providers should focus on a quality or affordability. I think so. That was a question. So I think so. We cannot have any one of it, because if you try to choose any one of it, then it's not a healthcare. So it has to be a hybrid. It has to be both together to make it more sustainable. And I'll come to the second part later. The first part, as a provider, definitely the quality need to be up, because you are dealing with the healthcare, and you are not dealing with some commodity wherein you can reduce the cost, because please understand, reducing the cost means you are compromising somewhere. Otherwise, as Dr. Parag said, everyone is up of the game in terms of to ensure that you park in better bottom line. So there's hardly a scope to reduce the cost. You can do here and there few things, and which may help you to park additional 1% to EBITDA, but not more than that. So quality has to be our prime focus, and what we have discussed since morning, which is, we are talking about AI, we are talking about robotics, that's all going to add to the quality, the final outcome to the patient, but that all is going to come with the cost. So quality has to be the prime. And then second thing, the entire model need to be sustainable, so that, that's where I said affordability also need to be taken care. Now there are various models which hospitals can actually work. Like there are certain models which are working in charitable institute, when we say certain percentage of your top line could be to the underprivileged, could be to IPF, indigenous patient, could be the weaker section of the society. So that's something which could be encouraged, and that has to be very inclusive with the private hospital players. It need to be set across, it need to be discussed with them, and you need to try and find out how does it work, because hospital is a place wherein you are basically aggregator. You are trying to bring everyone together, and you are trying to give a service, and that is what we call as a healthcare. It's little healthcare and more of a sick care, so we cannot take a chance again here. So you need to bring in all the stakeholders, right from doctors, right from pharmaceutical companies, right from everyone. So if you are looking at that certain percentage of your total capacity, and if it is going to come at some sort of privileging to the underprivileged, then everyone need to agree to that. And this, if you work on such kind of models, then those models could be more sustainable, and wherein you will be able to achieve quality, which is a prime motto of every provider in healthcare. You cannot disturb that. At the same time, you are able to reach out more and more people. I would like to take 1 more minute is, I think so somewhere down the line, overall we are forgetting our infrastructure still underdeveloped. As a country, we need to focus. We are talking a lot on IT, which is good, very, very good. But our overall infrastructure, the patient to bed ratio, the doctors to bed ratio, that's something which need to be focused. That is something long term, but it is sooner You know, sooner we do it, it is better. Rather than trying to see, you know, like how one can be multiplied. You can whip horses, but if you require 6 horses for chariots you cannot whip 2 of them. At some point of time, they will collapse. Then we may spoil the health system, which is really supporting, which is 70% of the health system coming from a corporate side or the private side. At some point of time, that may collapse because it's all about sustaining.
Yeah, thank you.
Thank you
No,
so much.
sorry to interrupt because I think the time is already up. So I'm opening, there are a lot of questions actually I wanted to ask because of the kind of panel that we have today, with the kind of experience that they have. But then I think the time is up, so we'll have to take a few questions from the audience. So yeah, we'll have 2 minutes to take the questions. I think, yeah, somebody can pass on the mic, please. Yeah.
My query is regarding, as you said, installing the HVAC has reduced the hospital-acquired infections. But there is installing that is in the NICU, I think, no? Right? You were talking about.
Your question to Dr. Hiren.
Yeah.
Okay. Yeah, you can.
Because it will invite a huge capital investment and huge maintenance costs, huge repairing costs.
Sir, my this thing was in pertaining to the situation where we are in. During the pandemic, like I said, our hospital was not geared for a airborne infection in the general area. So when you are having a mixed hospital, wherein you have extremely small weight babies, premature babies, who are very vulnerable, and you have a general population taking adult population there. So the general areas with the return air, in fact getting the fresh air coming in, mixing of return air was a problem in our existing setup. So that all we had to rectify to improve the air quality. Now, so what we are doing it is, like I said, since as we are expanding and we are getting other brownfield projects, all those defects in our existing infrastructure, we are avoiding. They are being taken care of in the design element itself. Having more natural ventilation, having separate areas where wherever, if suppose there is further another pandemic coming in, another viral load coming in, to be equipped so that we can deal with it. Because you have to understand there is a significant amount of population which really suffered at that time, because a proper NICU care could not be given to those babies, because we could not risk 50 other babies by taking in one child which was undetected. That is where I was.
So there were negative pressure HVACs were.
So we have more now of return air being taken out and fresh air inflow. And of course negative HVAC isolation areas. Though that is a separate area.
And little one more question. If 100 angioplasties under Ayushman Bharat are giving you a 40 lakhs of loss per month, then what makes you to continue to work under Ayushman?
What makes us continue under Ayushman Bharat is the fact that this generates some amount of, the angiographies generate some amount of bypass surgeries. So it's a little bit of Robin Hood Giri, yahan se lo, yahan pe do. The problem is also that in our vision statement, we do have to serve the needs of the community. So I don't know about other people, but we do live up to our vision statement, sir. Thank you.
You just cannot select one specialty. And cardiac is an emergency. You cannot turn patient off from your casualty.
So mix and match of cardiology and cardiothoracic would make it.
Yeah. Any more questions? You want to ask something? Somebody raised hand from this side, I think. Okay. I think that's Santosh. Thank you so much for the patient listening. Thank you, the panelists, for the wonderful interaction. And thank you for Economic Times and Alka, especially for this opportunity. Thank you so much. Thank you.